This video will review atrial fibrillation approach. This video will focus on AFib with RVR. Definition of that is atrial fibrillation with a rapid ventricular rate. That ventricular rate needs to be greater than 100. AFib with RVR patients are one of the most difficult patient populations to manage pre-hospital. The question always is AFib the cause of the illness or simply a contributing factor? Pre-hospital environment lacks the necessary diagnostic tools to make this determination. There is some good news though. The vast majority of these patients are hemodynamically stable, meaning that rate control in the pre-hospital environment is really not generally required. What about the unstable patients? We will break down a simple treatment modality in this video, but first we need to talk about patient assessment. The difference between treating your patient correctly and making them decompensate lies within your assessment. First thing you need to do is determine whether this is new onset AFib or chronic AFib. A little anatomy to review this. There is a left atrial appendage. This is physiologically normal. The left atrial appendage produces ANP and BNP. These two regulate fluid balance. We are not going to dive into that for this video. In AFib, blood will pool in the left atrial appendage. When blood pools, it begins to coagulate, which equals clot formation. This increases your risk of an occlusive disorder like CVA, MI, etc. So what is considered new onset versus chronic? If it's less than 48 hours, that's considered new onset, and that will determine whether rate control or rhythm conversion are appropriate. Look at a case review. You're taking a transfer to a 74-year-old male. He is diagnosed with pneumonia and AFib RVR. For the AFib RVR, his heart rate has been in the high 170s to the low 200s. Vital signs have been pressures 90s over 50s with MAPs in the low 60s. His respiratory rate has been in the high 30s, end-tidal in the low 20s, but his mentation has been maintained throughout. GSS is 15, ANO 4. So using that case, let's revisit that question. Do we think that AFib with RVR is the cause of the illness or simply a contributing factor to the illness? So we need to differentiate. Is this new onset? Should we do rate control or rhythm conversion? What if this patient is hypotensive or becomes hypotensive? Do we cardiovert or do we do rate control? Let's talk about some risks here. If we cardiovert, patient could convert to normal sinus rhythm, which would increase our risk for those occlusive disorders we talked about, like CVA, MI, etc. If we don't do anything about it, that high heart rate from the AFib RVR will likely cause decompensation of the patient before we get to the receiving facility. What I'm getting at here is these patients are difficult to manage, and so now we're going to look at how do we approach these patients. For the stable population group, it's very simple. We're going to provide supportive care. Really, that means we're going to monitor. That doesn't mean that you shouldn't give a bolus or provide oxygen, those things of course, but in terms of treating the AFib RVR scenario, we're just going to monitor it. These patient groups are heart rates maybe 140s, 150s, 160s, but they have a stable blood pressure. For the unstable population group, we'll look at three things. One, we'll treat and optimize. Two, we'll provide blood pressure support. And three, we'll eventually do rate control. First though, let's look at this treating inciting causes. So inciting causes mean things that are making the AFib RVR occur. So pain and anxiety, electrolyte disturbances, respiratory compromise failure like hypoxia, hypercapnia, even anxiety. Consider additional underlying causes such as alcohol, illicit substances, meth, cocaine, etc., previous beta agonist, fluid overloaded, some adrenergic states such as alcohol withdrawal, pain, agitation, anxiety, some neuro disorders such as CVA, seizures, MI or myocardial ischemia, and sepsis. After you've treated the inciting causes, the next thing we'll do is we're going to optimize hemodynamics. So for optimizing the fluid status, We're really talking about assessing for hypovolemia or hypervolemia. If we really can't decide if we are overloaded or underloaded in the pre-hospital setting, we can start with a small 250 cc bolus and kind of assess the pressure after that. For the diuretics portion, we're typically not administering this in the pre-hospital setting, but the ER might have done it on the transfer or gotten orders to administer it en route for a transfer. Supporting blood pressure, this was really meaning that we're going to do pressors. For us, primarily this is going to be levo and low-dose levo to start. There are better options that we don't carry, and likely we're not going to carry them. The reason for this is we can't carry every medication for every situation. The preferred medications would likely be vasopressin or neosynephrine. Again, they have much worse utilization when compared to Levophed overall, and that's why we don't carry those drugs. Next, what we can do is if they're already on epi or dopamine, we can transition to a less beta-adrenergic drug like Levophed. So if you get in and they're in AFib-RER and they're unstable and they're already on dopamine or epinephrine, one of the things that you can do is you can come off of those drugs while increasing to Levophed to maintain the patient's MAP, but reduce the beta stimulation, meaning the heart rate stimulation. Last part of this is rate control. So we treated our causes, we've optimized fluid dynamics, and the last portion of this is we'll do rate control. This is last resort. You should always consult the appropriate physician. That may mean on a 911 call that you're calling HGH or wherever you're going to take the patient to. On a transfer, probably the receiving physician to help make this decision. Some other options that we didn't talk about here is cardioversion, and then you would need to determine whether it's new onset or chronic, and medications that we would use for rate control and or conversion would be diltiazem. So, who is confused? Let's look at a simplified treatment option. So this is the simplified treatment pathway. This is everything we just talked about, condensed down to make it very easy to understand. So the first thing we're going to do always is treat and optimize underlying causes. We'll optimize the vital signs, we'll treat pain, anxiety, other of the inciting causes. Then, next thing we do is blood pressure support. That's going to either be fluid boluses, or if it's pressors, then it's going to be low-dose Levophed. After we've treated and optimized, and we provided blood pressure support, then the last resort, we're going to do rate control. Rate control is either going to be done through cardioversion or diltiazem. Both of these options I want you to call and have a discussion with a physician, whoever's going to receive that patient before doing this. For takeaways, most patients are hemodynamically stable, meaning that we just need to monitor them. 2, always err on the side of caution. If you're unsure, call for help. Always treat the patients in that order of treat inciting causes and optimize, pressure support, and then call for help if you determine that you need rate control. The assessment is key to this. You need to provide whether this is new onset or chronic when you're calling for rate control. Again, to review, the reason is if it's chronic AFib, they're probably already on some sort of anti-10A like Eliquis or another anticoagulation drug like warfarin to prevent the clot from forming. So doing rate control or rhythm conversion on this patient is far less risky than it is on someone who's a new onset AFib, and there could be a clot waiting in that left atrial appendage. You restore it to normal tennis rhythm, and then they have a stroke or an MI. Last portion of this is call for help. Call for help in any step. These patients can be very challenging in the unstable population group, and always seek advice and help if you're unsure. One final clarification. When we're talking about the unstable AFib RVR patient, we're not talking about someone that is unconscious, unresponsive, with no measurable pressure. We're talking about people that have a borderline MAP, maybe slightly less, but they're still sort of mentating. They're able to control their airway. For the patients that are unconscious, unresponsive, with no pressure, heart rates in the high 200s, 220, 230, something like that, then I want you to follow your ACLS protocol like you normally would. Likely 2 at that rate will be very difficult to determine whether it's AFib or SVT. This concludes the AFib approach video.